So how will you manage the airway and breathing according to the ATLS protocol?
Okay, management of airway and breathing according to HLS protocol starts by inspection. To inspect, when patient comes with a trauma, polytrauma, one will inspect. First thing to call for help, and then to speak to the patient first. When patient responds, when patient talk back, so it's an indication that the airway is cleared. However, if there is if the patient cannot respond, one should listen to the sounds, to the breath sounds. There may be googling sounds. There may be stridor, difficulty in breathing. It may be indication that there may be foreign body or tongue has fallen and blocked the upper airway, or there may be facial fracture of facial bones, maxilla also. So that can be the case in that case. So that is the assessment. So how to manage the airway in that case, if there is features of obstruction, one can use simple airway management maneuver, chin lift, jaw thrust, and then to check the mouth, use hand or use Magli faucet to remove any foreign objects that is in the airway. I want to give high flow oxygen, about 10 to 15 liters to ensure adequate oxygen flow. Usually, airway is managed together with a cervical spine. While one is managing the airway, one should ensure stabilization of cervical spine. So it's usually airway and cervical spine stabilization. The stabilization of cervical spine is to apply cervical collar, sandbags on this side, bilaterally on each side of the head and neck. Then to use adhesive tape, triple stabilization. Then for the breathing, one should also inspect, count the respiratory rates, uh, look at the accessory muscles of respiration from the chest, the neck, and the abdomen, and then listing and look at the chest expansion. This is expression. On patient and assessing the breathing, one should check the trachea, whether it's central or deviated in tension hematoma, intention pneumothorax or acute pleural effusion. The chest, the trachea can be displaced, and one should also check for the chest expansion, which could be reduced if there is a tension pneumothorax, and then one should percuss. Also, the percussion can give rise to hyperresonant percussion, not intentional pneumothorax, or in pleural effusion from hematoma, it could be dull or stony dull even. And one should listen with a stethoscope. If one listen, there may be absent breath sound where there is a pathology. So this is how to assess the breathing. So in that case, how to manage the breathing if assessment is done and then problem is found in case of tension attention pneumothorax, needle decompression can be done in fifth intercostal space, just anterior to the middle axillary line, and the air is expected
Okay.
to flow. Patient
So,
control is possible.
can you comment on the chest X-ray that has been provided to you?
Okay. This chest X-ray showed on the left, the yes, it showed on the left there is lung collapse. There is a pneumothorax, massive pneumothorax. There is rib fracture. There is obliteration of costophrenic angle, and the trachea is shifted uh, to the contralateral side, which is the left side, and there is subcutaneous emphysema as well.
Okay, so how will you manage this case?
Yeah, so this case, I will manage this case by doing needle decompression to pass a wide bore needle size 14 or size 16 cannula anterior to meet at the axillary line to drain the air acutely, then subsequently to follow with a chest tube to with chest tube insertion onto aseptic procedure, then to give patient oxygen, then to inform my consultant to also be consulted to a cardiothoracic surgeons.
Okay. So now the patient is found to have shock. How will you manage the circulation according to the ATLS protocol?
Okay, for the circulation, I will assess the peripheral signs, that is the capillary refill, pulse rate, blood pressure. I will assess and know the extent of the shock. I'm expected to have tachycardia and very poor capillary refill and then hypotension. So I will secure IV access with wide bore cannula in bilaterally in antecubital fossa and take sample for urgent blood count, electrolyte urea, liver function test, blood sugar, arterial blood gases, and clotting, and even to group and cross match and save blood at least 4 units. Then I commence resuscitation with IV crystalloids 1 to 1.5 liters to rush over uh, uh, 1 hour. Then I will reassess if there is improvement. I will notice improvement in the IV. I mean in the capillary refill, pulse rate, and the blood pressure is supposed to rise. And if there is no increase, I will uh, I will transfuse the patient with blood. Importantly, looking for any source of bleeding to arrest or any source of bleeding and arrest. While if there is no obvious source of bleeding, it might be internal. So I'll inform my consultant and inform the appropriate specialist for possible uh, uh, surgical.
Okay. So how will you monitor the response in this patient?
Okay, for response in this occasion, I will monitor the response by assessing the capillary refill is expected to respond at least less than 3 seconds. Then the blood pressure that might be uh, 80 over 50 is supposed to rise to at least 90 over 60 or 100 over 60. Then urine output also, I know some pass my catheter to monitor the urine output. I will aim at urine output of 0.5 to 1 uh, ml per kg per hour.
So can you tell me that in which stage of shock the blood pressure starts to drop?
In in stage 3 of hemorrhagic shock, the blood pressure start to drop.
Okay. So can you comment on the CT scan that has been provided to you?
Okay, this is a cross section null CT scan of a patient at the level of abdomen, putting through the liver, stomach, and the spleen. It shows liver injury. There is a liver injury, liver laceration at the mainly at the right lobe of the liver.
Okay. So can you describe what are the different grades of liver tear?
Okay, liver grades of liver tear can be liver injury. Grade of liver injury can be assessed or can be graded according to American Association for Surgery of Trauma, where grade 1 is subcapsular hematoma of less than 10%, or parenchymal tear uh, of less than 1%, while grade 2 is subcapsular hematoma of between 10 to 50%, or uh, parenchymal tear of 1 to 3%. Grade 3 is a subcapsular hematoma of over 1%, of over 50%, rather, of over 50%, or parenchymal tear of greater than 3%. Grade 4 is a major parenchymal injury involving 25 to 75% of a liver lobe, while grade 5 is a major parenchymal tear or major parenchymal injury involving over 75% of the liver lobe, while the final grades, which is grade 6, vascular If it's medial vascular injury, which is avulsion, hepatic avulsion, that's grade 6.
Okay, so what is the management of liver tear?
The management of liver tear depends on the grade. For early grade, beyond grade 2, it is conservative management to transfuse blood appropriately when there is low HB, blood transfusion, patients monitoring with hepatic assessments like ultrasound. That's usually suffice. While in severe grades, maybe grade 3, 4, they are need for uh, exploration and breathing can be assessed easily. Control can be done. Packing of the liver and become a hepatic space can be done. And Ujo on the abdomen is done for decision thereafter.
Okay, so is CT scan a good investigation in this patient?
In this patient, CT scan is not a good investigation because it's trauma and then
And the patient is in.
so the best thing is fast. Okay, focus assessment sonography protein.
Yes, so what are the 4 classic areas that we assess in fast scan?
Okay, the area assessment first scan includes the pericardial, perisplenic area, perihepatic area, and the pelvis and the pelvic area.